Okay, there we go. So I'm Amy Sheley. I'm the genetic counselor at the Cleveland Clinic that specializes in lysosomal storage diseases, including Pompe disease. I've been at the clinic for about 24 years now. And for several of those years, I've been working with our clinical geneticist, Dr. Angelica Irwin, who sees folks with lysosomal storage disorders, including Pompe, with me. So some people have been diagnosed by specialties other than genetics. So I wanted to give a little bit of an overview about, who genetic counselors are, what is genetic counseling, what do we do, and then who are the physicians that we work with in genetics, our medical or clinical geneticists. Talk a little bit about the roles of both of us, and then talk a little bit about how we work together. Dr. Irwin and I work together at the Cleveland Clinic. Every genetic center is going to be slightly different. So not everything will be the same anywhere you go, but just as an example of how we work things in our clinic. So genetic counselors are health professionals. So we fall under the, a lot of times you hear us called allied health professionals. So we have a master's degree specifically in genetic counseling. In that 2-year master's program, we get training in both the biology and genetics itself, as well as training in psychology and counseling. There's a national organization that certifies genetic counselors through a board exam. And then states individually are starting to license genetic counselors. And you can see that we've made good progress over the last several years now, with more than half of the states having licensure and 17 more in process. And the hope there is that we'll become recognized by Medicare as providers to help with reimbursement and letting our employers, get some money back from us with our visits, and get better coverage, more importantly, for our patients. So most genetic counselors have an undergraduate college degree in some related field, biology, psychology. Nowadays, colleges have a lot more specific majors. So, some people might have a major in genetics or biochemistry or molecular genetics or things like that. But I have colleagues that have had a sociology major. As long as you're taking prereqs to get into graduate school, you can major in what you want. It's a tiny field. There's only about 5,000 of us in the country. And there are 55 training programs in the United States, 4 that are additional ones that are in the process of development. Most programs admit somewhere around 10 people per year. So it's an incredibly difficult field to get into. I, for example, am on Case Western Reserve University's admissions committee, and they had 250 applications for 9 spots. So very, very challenging to get into school nowadays. You get training in genetic counseling, training programs across all areas of genetics, from things like Pompe disease to cancer genetics to prenatal genetics. And so a lot of people, once we graduate, find the area that speaks to them and subspecialize into that group. So I'm one of what we call our general genetic counselors here, who the way I explain it to people is, if it's not cancer related, if it's not cardiovascular related, and it's not pregnancy related, it's me, is the easiest way to describe it. But I have colleagues that specialize in one of those other 3 areas as well. So what genetic counseling is, there's technical definitions for everything nowadays, I suppose, but genetic counseling is defined as the process of helping families understand and adapt to not only the medical implications of whatever condition they've been diagnosed with or whatever conditions in the family, but also the psychological and the familial implications. Anytime we're talking about genetics, there's a potential for it to be something that's inherited through a family. And so even though I might have one person sitting in front of me, in some ways, the entire family is my patient, and I have a responsibility to those folks to some degree as well, especially in conditions like Pompe, where we have some treatment. So genetic counselors provide information and support to families who have members with either a genetic condition or maybe a birth defect, or to family members who might be at risk for conditions. So our jobs are to figure out who's at risk, say, do we think this is suspicious for a genetic disorder or Pompe, or could this be something else? So we investigate the problem, we interpret information about the condition, we take family histories on everybody we see to try to analyze how it looks like the condition's running through the family. We talk about the risk of recurrence is the fancy way of saying the chance for other family members to develop the same symptoms. We're helping with ordering and interpreting of genetic testing, and then talking about different options for testing and treatment with patients. We provide supportive counseling to families and know when to refer to specific psychologists and mental health professionals that have much more training in that area than do we. We try to act almost as a quarterback, so to speak, for our families that we work with, making sure that they're getting the appropriate care that they need and trying to facilitate communication among the different specialists if need be. Most people, like I said earlier, have never heard of genetics before. And that includes, sadly, a lot of medical schools teach minimal amounts of genetics. So we are acting as resource people, not only for public, but we're, consistently educating residents that are in medical school or, just finished medical school, or helping teach those folks as well. And then some genetic counselors do research in a specific area of genetics as well. So that's a genetic counselor. So a clinical geneticist, or the other term that's used interchangeably, is medical geneticist. So that person is a physician. So they've gone to medical school. And instead of specializing in just heart, like a cardiologist would do, or neurology as a neurologist would do, a clinical geneticist's main practice is focused on patients with genetic and hereditary conditions. So they have to have a good deal of knowledge in all organ systems, because genetic conditions can affect anything in the body depending on what the condition is. They are even a rarer breed than genetic counselors. There's only about 1,500 of them in the clinic or in the United States. And there's a couple different ways that doctors can become or specialize in genetics to become clinical geneticists. The more common route, I think, nowadays is something called a combined residency. And it's combined in one of three ways. So you can be combined in medical genetics and pediatrics, medical genetics and internal medicine, or medical genetics and OBGYN. And so geneticists really, even if you're trained as a pediatrician first or internal medicine doctor first, because genetics affects folks across the lifespan, geneticists and genetic counselors are trained to see people across the lifespan. But they tend sometimes to focus on one subspecialty or another. And that combined residency, so you finish your 4 years of medical school, and then you can do this combined residency in an additional 4 years. The other way to become a medical geneticist is to do a residency in another area. Say they thought they wanted to do neurology or family medicine, and then somewhere along the way in that training, they learned about medical genetics and realized how cool it is, and decided to do a fellowship in medical genetics. That fellowship is typically 2 years on top of the other residency, and residencies can be anywhere from 3 to 5+ years. So you're looking at usually about 5 to 7 or 8 years after medical school if you go that route. So here are some roles of a genetic counselor when we're working with families. And what's highlighted in yellow here, I think, are the skills that we have from training that physicians don't have enough time, I should say, to get as much of an emphasis on as we do. We're trained in how to take medical and family histories, draw out those what we call pedigrees, or the family histories on paper. We really try to facilitate decision making. Do people want to know if this is in their future, or they're going to be diagnosed with this condition, or do they want to know if they're a carrier for Pompe disease? We do a lot of, I call it genetics 101. Most people, if they learn genetics in school, wanted to forget about it as quickly as they can. And I joke with my families that it's my job to bring that nightmare back to people. So I think in order to understand the condition, you need to be able to understand the basics of genetics. So we try to talk about that in a way that's ignoring doctor speak, so to speak, talking in plain everyday language we all understand without using a lot of the big words that the doctors like to use. We help coordinate genetic testing. So by that, I mean, ordering testing, making sure kits get to families, sending out kits that we collect in clinic, dealing with insurances, and trying to get insurance authorization. That falls on the genetic counselor. We work in tandem with a geneticist to go over test results. So when we order genetic testing, we're the ones giving you those results. If we make a diagnosis such as Pompe, we're the ones, thankfully, most of us have a good amount of time to spend with families to talk about the condition itself and what it means, not only medically, but again, for the family. I routinely get at least 30 to 60 minutes with my patients, and our physician the same. So it's nice that we have the luxury of time that a lot of other specialties don't. Again, we talk about what that condition means to the family. What's the chance that your sibling or your child will develop the condition? And then again, some short-term support, psychosocial support, and guidance, because obviously it's a big change there, right? If you make a diagnosis, and especially if you all know better than me how unsettling, to put it mildly, it has to be diagnosed with a condition that you never heard of before or you don't know anybody else with. So especially if those folks are the first in the family to have heard about it, it's definitely we recognize the gravity of that situation, I think is the best way to say it. So the physician role, again, they also gather medical family histories. They think, if I didn't think to ask a specific question, Dr. Irwin will. One of the things that they can do that we cannot is the physical exam. So dysmorphology, are looking for physical features that might point somebody toward a genetic disorder, and looking for disorder-specific symptoms. So in this case, muscle weakness, breathing issues, those kinds of things. They're the ones making the testing plan, letting us know what specific genetic test they would like us to order. They also communicate test results sometimes. The other thing I forgot to highlight in yellow is the other thing that physicians can do that genetic counselors do not, because it's outside of our scope, is medical management decision making. So genetic counselors can go over published guidelines for medical management, and we can review with our families the plan that the geneticist is going to be putting in place, but it has to be the physician that's actually making those recommendations. And again, they can do a lot of the same things that we do. So there's a whole lot of overlap, I think, which is why sometimes it's confusing, the difference between our specialties. So your genetics team, I think it's safe to say that genetic counselors and clinical geneticists work very closely together. And like I said at the beginning, specific duties for the GCs versus the geneticists are going to vary from center to center. So I wanted to close with just a little bit about how Dr. Irwin and I work our Pompe clinic. So my role with Pompe is to see the patient first. We have back-to-back appointments. So I take medical and family histories or take updates to those. I'm doing a lot of the education that we talked about earlier, talking about how this condition is running through the family, who might else be at risk in the family, talking about Pompe disease itself, is it infantile onset we're dealing with or late onset, and going through those symptoms. I talk a lot about the pros and cons of genetic testing and the limitations of testing, like those stinking variants of uncertain significance that nobody likes to get. I can review the published medical management guidelines that Dr. Irwin will be going over in more detail. And then I can be a point of contact. A lot of times it is much easier to reach your genetic counselor than it will be your physician. You know, Dr. Irwin, I think, is pretty responsive, but you know, she's great. And I think a lot of geneticists too are busy enough that it seems to be the genetic counselor that's a point of contact. And then we can, if we can't answer the question, we can farm it out to the geneticist or whomever we need to do to get answers for our families. And Dr. Irwin's role at the Cleveland Clinic, she's going to review the histories, again, ask any questions that I didn't think to ask or answer any questions that I could not answer. She will do an exam, let me know what type of testing to order, and then in detail go over how we keep people as healthy as we can with Pompe disease, you know, what surveillance options or recommendations are there, talking much more in detail about enzyme replacement therapy and, you know, the benefits and risks of that. And then she also can act as a point of care for other physicians involved in that person's care. So here at the Cleveland Clinic, we don't manage infusions. We have an adult hematologist that does that part for us because they already have their infusion center set up in that department. So we can go back and forth with different physicians. She's constantly talking to experts in the field and expert physicians. And, you know, if we don't know the answer, she's reaching out to somebody who does. So it's very much a team effort. It very much overlaps. But I hope that makes it a little bit more clear and answers what, Heather, you were asking me to talk about today. But I'll answer any questions.
Thank you,
So
Amy.
we have a,
Mm-hmm.
oh, go ahead, Sean.
No, I was just thanking her, and I think I was gonna go on and ask the question that Allison asked. So Allison asked, do you find most people do want to know? I'm assuming that's referring to the part about what, you know, yeah.
Yes, and that's probably specific to Pompe for a couple reasons. Number one is that I think people self-select who come see me, right? So the people that absolutely want to know nothing about the genetic disorder in the family are not going to be the patients that get to me in the first place. You know, I do talk to some folks who decide not to know, but I think I'm already a little bit more likely to be talking to the people that want to know. And then in the case of Pompe disease specifically, I think because it's a progressive disorder that gets worse over time without treatment, and because it's one of the few genetic disorders that we actually have treatment for, I think that adds another layer of want to know to patients. So yeah, most people for this condition, yes. I work with other disorders though, for example, Huntington's disease, which is a fatal disorder for which there is no treatment or cure. And I'd say at least half of people with that in the family choose not to know if that's in their future.
Okay, thank you.
Mm-hmm.
Anybody else have any questions?
I just wanted to ask Amy, you said that that genetic counselors are often trained in counseling, some part of counseling. Do you have to do continuing education credits like a social worker or a therapist would have to
Absolutely.
do?
We do, both to keep our certification and to keep our state license. So we're licensed through the medical board here in Ohio. I think most states license through their medical board. But I know I have to get a new license every 2 years, and I need 30 hours of continuing education over the course of 2 years to keep my state license. And then for my national certification, I need 125 hours every 5 years. I mean, what I learned 24 years ago, some of it is, I'm the dinosaur in my department. Some of the the genetic testing techniques and things that we thought we knew when I trained in school aren't even being used anymore. And so if this is not a field for somebody who doesn't like to continue to learn, because the field is advancing so much, so fast, so quickly that, you know, if you don't keep up, you're gonna be providing terrible patient care.
What's the difference between the local license and, I'm sorry, Tony. Real quick, but what's the difference between the local license and you said there was a national license?
Yeah, a board certification. So the
Board
certification it was an 8-hour exam that we took that thankfully we only have to take once, that goes over, you know, everything that we were taught in school, and we have to have so many cases under supervision and things like that. And that's how we got certified as a license, or as a what we call a certified genetic counselor. And then most states are not really requiring any additional education to become licensed as a genetic counselor, but they require you to show proof of your national certification and that you're in good standing with the American Board of Genetic Counseling in order to get your state license. Does that make sense?
It does. Thank you.
Amy, could I ask a question, please? I've just recently been genetically tested, and they found 2 variants, one on the GBE1 gene and the GAA gene, but only show as a carrier. But I have quite a lot of the symptoms. Do you come across clients like that?
Occasionally, and you know, I have to speak in generalities because I can't be your medical professional, but sometimes it depends on how folks were tested. You know, I've worked with families in the past where they've had a genetic testing method called genotyping, which is looking for the hotspots for mutations within any given gene, including GAA for Pompe disease. And you're missing sometimes that second hit. So you might be missing a deletion of that gene or a rarer mutation that hadn't been described much before. So occasionally we want to make sure people have had full sequence. It's called full sequencing of the GAA gene, and that includes a deletion analysis.
Thank you.
If they have,
Tony, are you the guy from New Zealand? Sorry to butt in.
Yes. Hi, Alison.
I was looking at your name and I thought, oh, I wonder if it's the same guy.
It is.
Yeah.
Great. Nice to see you in person. Facebook
Absolutely.
friend me.
Yes.
We're all over Facebook. Yeah.
Vanessa asks, do you ever recommend alternative or additional therapies such as nutrition and or exercise?
Yes, our physician does. She has definitely recommended, you know, keeping as physically active as you can, physical therapies, things like that, anything, you know, to try to keep the muscles in as good a shape as we can, knowing that this disorder attacks the muscles. And I think the more you work out, the more it's going to help your respiratory muscles as well, right? And then certainly she has recommended nutrition before to patients as well. She's very good. And I think most geneticists are very good at really trying to get our patients and our families to help direct their own care. It is not often that she says to a suggestion of a patient that this is not a good idea. I can't think of when that's happened last with Pompe specifically, but in general, they're pretty good about doing that. I think compared to other specialties, we tend to, because we're dealing with the whole body, it's easier to remember that we're treating the whole person than some doctors that really focus on one little piece of the body.
So I see Dr. Irwin, who is the doctor that Amy works with. And she actually, so my neurologist, I found myself because I called the Cleveland Clinic after I got diagnosed and I said, I need a neurologist that specializes in Pompe. and they connected me with her. But all of the other doctors that I see as part of my care team, are doctors that she found because they either know Pompeii or they were willing to learn. And the
Mhm.
ones that are willing to learn, she teaches them. She just, again, she's another person that I'm feel so fortunate to have as part of my care team. Because she really does spend time making sure that the doctors that I'm seeing know this disease, but also know me as a patient. And when I've been overseas, I've referred my doctors to her and she talks to them. And like Amy said, she's super responsive. Like I'll email her and within an hour sometimes she'll respond, she will have responded to my email. But she definitely is looking at me as a whole patient, as a whole person, and saying, recommending things to do that are best practices to help keep me healthy. Do we have any other questions?
Well, thank you.
Thank you, Amy.
Thank you.
All right, it was good to see you. I will hang up and let you guys finish.
All right, thank you, Amy.
All right,
Actually,
Amy.
can I want to email you. You brought up being a part of the admissions board at Case Western.
Mhm.
So do you know Aaron Goldenberg, I think?
I don't think
He's in-
so.
Okay, he is a professor there. So,
No, I'm
I
only
would-
on the admissions committee for the genetic counseling training program. So
okay,
very
because I was
fine.
trying to connect with him during Pompeii Awareness Day and invite him and some of his students to our meeting.
Oh,
But he never responded to me.
Mm.
So I wanted to
Yeah,
know
we're
if
not
maybe
aware.
you had an inside track or something.
Send me the name. I can always ask my colleagues
Okay.
if anybody knows him.
Awesome.
right.
Okay, great.
Take
Thank
care,
you so
everybody.
much. It was good to
All right.
see you.
You too. Take care. Welcome home.
Thank you.
Bye.
Bye-bye. Okay, I'm going to stop the